I'm going to talk about caveats of treating cellulitis. So let's move to our patient. So we have a 72-year-old non-patient with type 2 diabetes mellitus on oral hypoglycemics with a good compliance and control. So she presents with a history of fever and chills and rigors with the red, swollen right lower limb, which you can see in the right side of the screen. So she's having a temperature. She's pyrexial at 39.4 degrees Celsius. Her vitals are stable, and she's admitted to the medical ward. And her blood sugar is 154 milligrams per deciliter. So what is your differential diagnosis? So obviously the talk is about cellulitis, and you can see the swelling, erythema of the lower limb, and she complains of pain and she has a temperature. So your diagnosis is going to be cellulitis. And this can get complicated with necrotizing fasciitis, which is a severe form of cellulitis, where she will be having disproportionate pain as well as crepitus. But mind you that all that is red is not cellulitis. So your patient might have a chronic venous stasis dermatitis, as you can see in the right side, or this could be skin overliner septic joint, or this patient may be having a deep vein thrombosis. So whenever you are seeing patients with possible cellulitis, you need to keep the differential diagnosis in your mind as well. So what are the risk factors this particular patient is having, right? So if you categorize the risk factors under three main domains, it can be due to deficiencies in the immunity, it can be due to deficiencies in the skin integrity, or deficiencies in the vasculature. So in this particular patient, her old age, the presence of diabetes, obesity can be risk factors. And also one of the strongest risk factors for cellulitis would be having a positive history of previous cellulitis. And then the patient can be having congestive heart failure or malnourishment, which can be contributing. So what are the positive organisms in this particular patient? Right, so most of the time the cellulitis is due to infections of Streptococcus pyogenes and Staphylococcus aureus. But occasionally you can have patients having or growing strep pneumoniae, Haemophilus influenzae, or gram-negative bacilli and anaerobes in patients with cellulitis. But particularly in patients who have very poor control of diabetes, you can get polymicrobial infections. So generally cellulitis is monomicrobial. Most of the time you are able to isolate only one organism, but in patients with poorly controlled diabetes, it can be due to multiple organisms. So in this particular patient, in your clinical assessment, you need to inspect the skin, looking for a source of infection, maybe a microabrasion in the skin due to injuries, insect bites, pressure ulcers, injection sites, or tinea pedis or fissure in between toes can be the culprit source for the infection. And also in patients with cellulitis, you need to consider blood cultures, particularly if the patient is at risk of gram-negative infections or patients with severe forms in septic shock or severe sepsis. And also immunocompromised patients, you need to consider getting blood cultures before starting antibiotics. And then every cellulitis patient does not need imaging. So no place for routine imaging with ultrasound or Doppler. But if you have a clinical suspicion of DVT, you need to consider excluding that with a Doppler. So we'll move to the main part of the talk. So what would be the best empirical antibiotic for this patient? So I have given you four choices: IV flucloxacillin, IV ceftriaxone, IV coamoxiclav, and IV flucloxacillin with clindamycin. So I give you 5 seconds to recollect your thoughts, and we will see what is the best empirical antibiotic. Right, so the answer is IV flucloxacillin. So let me explain why I am giving IV flucloxacillin over the other antibiotics, which can also be used in this particular patient. Well, so optimizing antibiotics. So generally, as I said before, the cellulitis is monomicrobial and commonly due to strep or staph infections. So the flucloxacillin would be the first line antibiotic. So you can start with 1 gram 6 hourly, not 500. So 1 gram 6 hourly, but if you have a patient who has severe cellulitis or who is bacteremic, then you can consider higher doses like 2 grams 6 hourly. And then you might wonder, why not IV coamoxiclav? Because that is one of the common practices that we use IV coamoxiclav to treat cellulitis. But when you think about the amount of penicillin type antibiotic that we can give to the patient, in coamoxiclav, the maximum we can give is around 1,500 milligrams per day if you go for the standard dosing. But by giving flucloxacillin, 1 gram 6 hourly, or in severe forms 2 gram 6 hourly, you can go for a very high dose of penicillin antibiotic, which will be very effective in treating cellulitis. And in non-severe forms, you may use it with clindamycin, right? So you can give clindamycin with oral flucloxacillin in initial days to get the momentum. But importantly, if you give a longer duration of clindamycin, that can increase the Clostridium difficile infection. So it is just to get the momentum, and then you can switch back to monotherapy. And the other important thing is we do see patients being prescribed IV clindamycin, even the non-severe forms. But clindamycin is a drug which has an excellent bioavailability, the oral drug. So preferably you can give oral clindamycin than going for IV clindamycin. But if you have a patient who has a severe form of cellulitis, who is bacteremic, whose blood pressure is low, who is septic, in that case, you can consider IV flucloxacillin high dose, 2 gram 6 hourly, in combination with IV clindamycin. But then we encounter patients who are doing very poorly in the background of poorly controlled diabetes, or patients who are immunocompromised, maybe a post-transplant patient, or maybe a patient who is on certain medications for chemotherapy drugs or something like that. So in that case, you need to consider a broad antibiotic cover. The reason being, this could be polymicrobial, and this can be, patient may be having gram-negatives. Or else this may be a case where the patient has a bad pyelonephritis with cellulitis. So in that case, we have to hit hard, and we have to cover a broader spectrum of antimicrobials. So then the choice would be to go for drugs like ceftriaxone or piperacillin tazobactam or meropenem with or without gentamicin. Right, so this is a snapshot from the current guideline where you can refer to. So I have actually summarized most of the things with my previous slide, just to familiarize yourself with the existing guidelines in Sri Lanka. Right, so this particular patient on day 4, she complains of severe pain, out of proportion pain, and she has high spike in fevers, and you can see the leg, there are blister formation, there is blackish discoloration, and you can feel the crepitus in the leg. So what is your diagnosis and what is your management? Well, with the out of proportion pain, with the presence of crepitus and this picture, you will make a diagnosis of necrotizing fasciitis. So what is your management? So I have given again 4 choices. This is not a single best answer. So IV flucloxacillin high dose with IV clindamycin, IV flucloxacillin with oral clindamycin, and change to piperacillin tazobactam with clindamycin and refer to surgical team. Right, so again take a few seconds to think what you will do for this particular patient. This is going to be one of the common encounters in our day-to-day practice. Right, so this is what we have done. So we have referred the patient to the surgical team, and they have done an excellent job. They have debrided the wound, they have done some fasciotomies, and they sent back the patient to the medical unit. So this is very important in treating or managing complicated cellulitis, which is meant by source control. So you need to control the source. Otherwise, the antibiotics alone will not work. And then we have escalated the antibiotics. Now the patient is on piperacillin tazobactam 4.5 grams 8 hourly with IV clindamycin. The reason being, we suspect now for the necrotizing fasciitis, this could be polymicrobial, particularly in patients who get neck fash, who are elderly, who have a history of diabetes. It is going to be a polymicrobial infection. So you have to hit hard, and you have to cover a broad group of microorganisms. And then this is likely that with this presentation, the patient may be having a renal impairment. If that is the case, you need to give a renal adjusted dose of IV piperacillin tazobactam. So although this patient had excellent glycemic control when she presented, with this necrotizing fasciitis, sugar can be all over the place. So the patient needs a very good glycemic control. So we have managed like this, and the patient was taken over by the surgical unit because there's a large wound which can be difficult to manage in the medical unit. So the patient got frequent wound debridements. Right, so again, summarizing what I have just mentioned, the necrotizing fasciitis can be monomicrobial, or sometimes it can be polymicrobial, particularly if there is a history of diabetes or history of immunosuppression, and if the patient is elderly. Then you need to go for a broader cover, preferably with meropenem or piperacillin tazobactam with or without clindamycin. Right, so again, to summarize the treatment of complicated cellulitis, the surgical exploration is very important. We need the surgical colleagues, and this is the only way to establish the diagnosis of necrotizing infection. So we need to send the cultures, and we can send intra-op specimens for Gram-stain, where we can get the answer, what is the organism then and there. And the antibiotics need to be escalated, so piperacillin or meropenem with clindamycin, as I said before. And generally here we recommend in high doses of clindamycin. The reason being, clindamycin is an excellent antibiotic, and also it has antitoxin effects. So most of the time, this necrotizing fasciitis can be due to the presence of toxins produced by microorganisms. So until the satisfactory tissue debridement, and if the patient is getting better, you can consider keeping the patient on high dose clindamycin. So the same patient on day 7, the blood cultures and the tissue cultures during the surgical debridement both grew Staphylococcus aureus. And this is a methicillin sensitive Staphylococcus aureus. And the patient is clinically doing well. Then it is high time to consider de-escalating from broader cover to IV flucloxacillin, right? So you need to de-escalate from IV antibiotics to IV antibiotics. So if the patient's blood culture is positive, generally we would recommend to give a longer duration of IV flucloxacillin because of the risk of bacterial endocarditis. And then we need to consider when to switch to oral antibiotics. So the de-escalation is equally important as escalation in treating infections. So the IV OST, the IV to oral switch therapy. So the oral switch we can consider if the patient's cultures are negative or only the tissue culture is positive. So from IV flucloxacillin can be de-escalated to oral flucloxacillin with clindamycin. So if the patient goes on a broader cover like piperacillin tazobactam with meropenem or with or without clindamycin, a suitable alternative would be to switch to oral levofloxacin. And then finally, what is the duration? So the duration of antibiotics is generally guided by the patient's clinical response. It differs from infection to infection, and it differs whether the patient had a full debridement or not. So generally, 7 days of IV after achieving full debridement is what is recommended, and after that, the patient can be switched to oral antibiotics for another period of time. Right, so coming to the last slide of my presentation. So we have discussed about antibiotics, we discussed about taking cultures, we discussed about starting the empirical antibiotic and when to escalate, when to de-escalate, and what is the duration of antibiotics. And then what are the other measures that she needs to be offered. So she's in quite a lot of pain, so she needs adequate analgesia, she needs to be monitored, and the fever needs to be managed. And the oral intake may be very poor, so there should be adequate hydration. And then the affected limb can be elevated, the glycemic control, and also if there are blisters, the aseptic aspiration or de-roofing of the blister. And the other common practice that we do see is patients with cellulitis are being prescribed topical antibiotics like fusidic acid to be applied over the cellulitic limb, which is not the practice and which should not be used in the management of cellulitis. Coming to the last bit, does she need prophylaxis? Is she at risk of getting another cellulitis in time to come? So particularly in patients with 3 to 4 episodes of cellulitis per year, and if she has a predisposing factor, say for instance lower limb edema or chronic lymphedema, an ongoing dermatitis or a venous eczema, if that is the case, it is good that if we can put the patient on antibiotic prophylaxis. So generally what is recommended is generally what we tell is oral penicillin prophylaxis. So that brings the end of my presentation. So in summary, I have discussed essential things with regard to management of cellulitis. So hope you will, the take-home message would be selecting the appropriate empirical antibiotic, and then when to escalate and when to de-escalate, and the duration of antibiotics that you need to be the patient need to be given in the management of cellulitis. So that brings the end of my presentation, and thank you very much for your patient listening.